Hello, it's great to be with all of you here today to talk about how we can personalize ICU nutrition using new tools to objectively measure nutrition and muscle mass for our patients. Briefly, my conflicts, or I'd like to call them alignments of interest. I'd like to believe I'm in alignment with all of these groups, both NIH and industry funding, to improve the outcomes of patients. And so I think one of the key messages I always want to share and would like to share with you today is we need to take responsibility, not just for outcomes in the ICU for our patients, the things we do on rounds that get the patient to the next day, but what can we do on rounds every day that helps get patients better able to recover after ICU as well. We always need to be thinking about what happens to them afterwards, because ultimately what we want is to create survivors of our patients. Survivors that go back to their families and go back to lives worth living, not victims of our patients. Victims that perhaps never get off the ventilator, perhaps never leave rehabilitation centers and never go back to the life worth living. Because ultimately what our patients want is to be able to go home and walk down the street with the people they love again and be able to spend time holding their grandchildren, holding their children, being with their families again. And this is more challenging than ever right now as our patients, with the advent of COVID-19 and the severity that has brought to critical illness, getting patients both optimal, objective, personalized nutrition and even physical therapy is harder than ever with all of the challenges our patients face. And so we're going to need to be better if we're going to optimally save our patients both in the short run and give them back a quality of life in the long run. But how can we do that? Well, I think the first message is that one size does not fit all when it comes to nutrition, just like it doesn't fit everyone when we do other forms of critical care. We need to personalize our ICU recovery and nutrition strategies using the right strategy and the right dose, for instance, of nutrition in the right patient at the right time, and we have to be measuring. We would never give vasopressors without measuring a blood pressure. We shouldn't be giving nutrition and perhaps even exercise without measuring how much our patients need and the effect it's having on their muscle and how we can better personalize and target what we do so that we're consistent with other areas of critical care. And again, I can't emphasize this enough. We can't measure it, we can't improve it. Lord Kelvin said this, and I wrote a brief editorial recently for an issue on a new personalized medicine interventions, and specifically on the objective measurement of nutrition and metabolism in the ICU and how we have many new devices to do that. And this is a summary of what we're going to talk about today. Some of these new devices include new metabolic carts, new muscle-specific ultrasounds, new bioimpedance analysis, body composition devices, and even some new exercise targeting through CPET and targeting and personalization of exercise. So I think before we even start, do we know who the most at-risk malnourished patients are? And is there a better way to measure malnutrition? And so how can we better not only measure who's malnourished, but also monitor what we're giving our patients more accurately, and what new tools do we have to assess them? Because the real question is, who is at greatest risk, say, from a stay in the ICU? Is it this relatively healthy, thin, elderly man, or is it this more obese young man? What role does body composition, obesity, BMI perhaps, but really muscle mass play on the outcomes of our patients? And the reality is, if you had to pick the best BMI to survive critical illness, heart failure, COPD, cancer, trauma, really any serious insult or illness in the body, your best BMI is actually 31. So it's in the 30s, and this is true in critical care as well. As you can see, in ARDS, the mortality from ARDS declines all the way out to a BMI of almost 40. And so the data seems to say that as our BMI increases, perhaps our survival rate actually increases. This is counterintuitive to what a lot of us believe. And again, this may or may not be true in COVID. It looks like there are some risk factors for adverse outcomes in COVID from being obese, but in general, in our ARDS populations before COVID, being obese, at least moderately obese, had a benefit. And this was true in general ICU patients as well. You can see the risk of death goes up dramatically below BMIs of 25. So people out there with low BMIs of 20 to 25, you're actually at greater risk of death in the ICU than, say, someone with a BMI of 30, minus 31 for those of you who are interested. And so one of the challenges of all our ICU nutrition trials is almost all our nutrition trials have been done in higher BMI patients, perhaps who are at the lowest risk of death, perhaps least likely to benefit from nutrition, first of all. And so we really need to start to study high metabolic risk patients and these low BMIs as well. And I think that's something we need to think about for the future. But I think one of the most critical pieces of data that's come out recently was in the Blue Journal. And this was a study that showed that there was a 7% decrease in the probability of recovering functional quality of life for every 1 point decrease in your BMI, such that a woman with a BMI of 22 had a 60% lower likelihood of recovering functional recovery, or conversely, a woman with a BMI of 30 was 60% more likely to recover meaningful functional quality of life, be able to walk again and go back to their activities of daily life than someone with a low BMI. And again, the death risk is higher for the low BMI patient as well. And there's good data for this. And so again, that being that thin patient isn't always to your benefit. And I think what we really need to understand is, what is it about these patients? Perhaps it's they have greater muscle mass. And really what we think is it's not BMI, but muscle mass that will be critical, because that's really the question. What makes someone metabolically and nutritionally fit? And do we have tools to assess it? And I think a lot of us believe that it's really your underlying muscle mass that is one of the key measures of your metabolic reserve and your chance to survive. And we have data for this that exists, and this data is growing rapidly. You can see that patients with low muscle mass there in the green are much more likely to die when they have low muscle mass at admission to the ICU than patients who have higher muscle masses. And this was wonderful work by Peter Weiss's group. And so the CT, which is what was used in this study, is a really excellent way to measure this. And these are just routine CTs we're getting for other purposes, abdominal CTs and other. We can measure muscle at the L3 vertebrae, at that cut, using free software called Slice-O-Matic that all of you can use. And I think we have a lot of data to show what a critical role muscle mass plays in outcome. This is a study that Rosemary Kozar did that showed that in trauma patients, free living trauma patients who were getting in car accidents, who had a mean age of 79, 71% of these patients were sarcopenic when they were admitted to the hospital. And so again, the challenge here was you couldn't look at these patients and tell who the sarcopenic patients were. There were equally large numbers of patients who were sarcopenic in the underweight, normal weight, overweight, and obese populations. And so again, looking at the patient was not able to correlate. There was no correlation between BMI and sarcopenia. So you can't look at the patient and understand what their muscle mass is. But what we do know is that low muscle mass leads to a doubling of mortality, with other things being equal, in these patients. So again, sarcopenic patients are at twice the risk of death in these elderly trauma patients who otherwise were living at home. And so can we do better? We really need to do better to assess sarcopenia, low muscle mass, and nutritional or metabolic fitness. And what tools do we have? So we talked about the CT scan and MRI options. MRI can also be used to measure muscle mass. There are surrogate measures like BMI, which aren't so great. But then there's the ultrasound. And the ultrasound is a really excellent way to measure not only lean body mass and muscle area or muscle content, but glycogen and muscle quality or neuromuscular fat as well. And so this is a very easy test to be done. You can use the ultrasound you have, or I'll tell you about muscle-specific ultrasounds that are really excellent, telling you many more variables. We've taught lots of different groups of people to do this: physicians, nurses, dietitians. Many people can do this testing, and you measure the leg muscle. And what we know is that muscle atrophy, when measured by ultrasound, is associated with survival and multiple organ failure. And this is data from Zudin Punzacheri that he's shown us this. And again, we know that there is some correlation between quadriceps muscle and CT scan, although one of the limits of this Validum study was that the CT scan and the ultrasound could be obtained as much as 72 hours apart. And we know that you can lose 10% of your lean body mass in the first week. So even just a few days can lead to great variability in loss of muscle mass over that first week period. And so a study that measures ultrasound and CT at the same time point, within minutes perhaps, or hours of each other, we believe could be much more accurate. So are there things we can learn from how athletes are using these new techniques, such as ultrasound, to help our ICU patients, even Tour de France athletes using these at the highest level? And so this is a new muscle-specific ultrasound device that's being used on the Tour de France by Real Madrid and by American sports teams, such as the Dallas Cowboys in American football, to help them train and nourish themselves better. And so this muscle-specific ultrasound is called the muscle sound. It actually almost takes a muscle biopsy by ultrasound. It colors the muscle based on the amount of glycogen or energy stored in the muscle, with dark areas having higher glycogen and light areas having lower glycogen. So it also measures muscle mass, and it also measures muscle quality with fat, which I'll show you in a moment. And so it's a little bit like getting a muscle biopsy and really understanding what's happening in the muscle. Are the nutrients being taken up? And it's very easy. It's a probe that's about this big. It plugs into your iPhone or iPad, and it can in minutes give you these muscle readings at the bedside on a daily basis if you'd want them, and it keeps the data and stores it in a really nice way. You can see how easy this is to do. You can see in this video that a very simple measurement's being made here, that it even auto-corrects you and tells you how to get the right image. And if you haven't gotten the right image, it tells you that. It actually has algorithms to tell you that. And so again, this muscle-specific ultrasound then colors the muscle, and it tells you where the glycogen is the highest or the lowest, and it gives you an average score. And this is used routinely by athletes around the world. And why is glycogen so important? We know that muscle with low glycogen content lowers the ability to perform, whether that be performing on the sports field or walking down the hospital hallway. And so you want your muscle to be taking up the nutrition. It tells us about our patient's ability to take up nutrition. And glycogen depletion leads to muscle damage and poor muscle function and recovery. When the muscle runs out of glycogen, it has to use amino acids. It has to break down the muscle proteins to get the energy it needs. And so then the muscle can't grow and can't be anabolic. And so with depletion of muscle glycogen, which we can measure, it cannot be anabolic. So what happens to muscle glycogen levels in these patients? This is what an athlete, a perfectly trained athlete, looks like. You can see how dark the muscle is. That's the water following the glycogen, and so it gives you the dark appearance to the muscle. This is an average individual with an average score. Score is 0 to 90, and this is 65. And this is what happens in different groups. This is what a rested athlete looks like. This is what a sedentary average person looks like. This is after 2.5 hours of cycling, like racing cycling. This is after a marathon running, 26 miles, 50 plus kilometers. This is what our critically ill patients look like when we measure them. It's like running 5 or even 10 marathons. And this happens very rapidly within 24 to 48 hours. This is what the muscle of a critically ill patient looks like. See how white the muscle is. The glycogen is completely depleted. We'd never seen scores of 0 in anyone, even athletes, until we started doing this kind of testing in ICU patients. And so different critical illness patients have different appearances. In fact, you can see the light purple and the muscle injury in green there that's happening in this sepsis patient versus what it looked like, the patient looked like at ICU admission, where the muscle's darker purple. Neurotrauma patients perhaps don't have the same forms of muscle glycogen loss as a sepsis patient. So different diseases and different diagnoses have different appearances. But what we found in our critically ill sepsis patients and trauma patients was 70% had muscle glycogen scores of 0 within 48 hours. And so there's this dramatic loss of glycogen that leads to muscle breakdown very rapidly. This puts patients at great risk. And actually, we can begin to see the muscle recover. You can see this was a patient at day 3 with a muscle glycogen of 0. At day 8, as the patient's improving, the glycogen begins to improve. And this may be the point at which we transition out of the acute phase and into the chronic phase, and we know we can feed more and actually have the patient be able to take this nutrition up more effectively. And so this may be a transition point from the acute to the chronic phase of critical illness. And so this may be the potentially anabolic time when we can begin to expect nutrition to be increased and the body to be able to use it. And it's more than just muscle mass, right? It's muscle quality. You can see the fat infiltration of this post-autopsy specimen in the muscle. It's dramatic fat infiltration. And that also predicts outcome. The same group, Peter Weiss's group, showed that muscle quality, intermuscular fat accumulation, leads to poor survival. And in fact, this intermuscular adipose tissue, which is what IMAT means, leads to poor survival as well. And this basically means fat is accumulating in the muscle because the patient can't utilize the calories we're feeding. And so this is something we can measure as well. And so this is a new marker, the IMAT index. And you can see, especially on the one side there, the incredible fat infiltration that is occurring. And it doesn't always happen consistently across muscles. But you can see it can be measured, and then it can be integrated by the ultrasound device. And so these are different patients. And this is how we measure intermuscular adipose tissue. There's an algorithm that the software does that allows it to do this. And so we've done this in athletes and in healthy controls, and they don't change much over time. But the ICU patients significantly increase their intermuscular adipose tissue over time. And when IMAT goes down, muscle fat is going up. And so that is a clear sign that the patient's not utilizing calories and the muscle is not metabolically healthy. And so again, significant increases in muscle fat and adipose tissue in the ICU patient. And Zudenbuch again has shown that there's an inability to use lipid and to use nutrition in these patients that leads to skeletal muscle bioenergetic failure or compromise. And so there's dysregulated lipid oxidation. That's why we think this adipose tissue accumulates. And so ultrasound is one option. BIA is another. There are much more advanced BIA devices in the scales you step on. And this is how current is passed through the body through multiple electrodes, not just something you stand on in the patient. And it can measure fat mass and calculate lean mass and body water. And so there's new generation BIA devices that we're using at Duke and around the world. And Arthur Van Zanten's written an excellent paper in an issue I edited for John Louis' Current Opinion Journal that talks about it. It's one of the best papers I've ever seen on BIA, and I really encourage you to read it, about how you can use this in your critical care patients. And so there's a lot of promise for some of the measures, including the phase angle. And in fact, there's been interesting data in COVID patients measuring the phase angle that show that low phase angles are significant predictors of COVID mortality risk at admission. And we have data that showed that trends in the phase angle that we'll publish soon also show that increased risk. And perhaps we can be measuring phase angle as a function of our ability to adequately feed the patient and have them take it up. And so body composition should be included as part of a routine clinical assessment of patients, we believe, because a lot of information can be gained both for diuresis purposes and body water, and also for the phase angle and body mass composition and body fat calculations. And so this is an example of what that looks like. This is the readout from the phase angle. And this is from what looks like an overweight patient based on BMI, but actually a patient who has a very high muscle mass. And so you can see they have a very high skeletal muscle mass, a low body fat index. And that's because this is a bodybuilder. This is an elite athlete who has a lot of muscle mass. And that's why his BMI is high and his weight is high, but his muscle mass is also quite high. So again, and also the patient has this individual has a very high metabolic rate, which the BI can calculate. Then what about one of our patients? This was a ICU patient post sepsis and shock, who had a very high body fat. You can see what the patient looked like here. Let me show that again, actually. And again, you can see this patient has a very high body fat, a very low skeletal muscle mass, and this is a very cachectic patient. And so again, these kind of measures are something you can get on a daily basis in 5 minutes that can really help us assess where our patients are at metabolically. And so again, we can use multiple modalities to measure the different phenotypes. This is what the reference slide here is, what a normal muscle ultrasound looks like with normal muscle glycogen. And again, that can be incorporated with the BIA. This is the athlete with very low fat. You can see on the ultrasound as well as on the BIA, a very large muscle mass, which also can be measured both on the BIA and the muscle ultrasound. And so this is a way we can integrate this kind of data. So what about how we measure how much we need to feed in critical illness? We need objective measurements to guide us, especially in COVID-19. Well, if available, energy expenditure should be measured by direct calorimetry. That's what all our guidelines say. So I encourage all of you to get an indirect calorimeter. And now the good news is there is a new accurate one I'll tell you about that's out there. And even in COVID-19, we've been doing this routinely in our COVID patients, and the FASPEN guidelines say this can be done safely. So you can do this. And the reality is indirect calorimetry guided feeding improves mortality. So feeding your patients via an indirect calorimeter in our most recent meta-analysis, there's also one by Pierre Singer that was just published as well, shows significant reductions in mortality when you use an indirect calorimeter to feed your patients. And luckily now there is a new indirect calorimeter. We worked with a group from around the world, these are names you'll recognize, with Claude Bouchard and Metaburger and others, to build a better metabolic cart with a grant funding from FASPEN, the European Society for Nutrition, and working with industry to build a better device. And this device we built is highly accurate. It calibrates itself, so we don't have lengthy calibrations. It's calibrated by mass spec, so it's very, very accurate. It's portable, it's affordable. This is, we believe, a revolution, a really significant improvement in our ability to care for ICU patients from a nutritional perspective. And the measurements can be made in as fast as 5 minutes at FiO2s up to 70% and higher peeps than ever before. So luckily, we had a number of these devices when COVID-19 started. This is Jerome Mullinger. He spent thousands of hours in COVID rooms making longitudinal measurements on a daily basis of the metabolic needs of COVID patients. Because this is a new disease, we need to understand the metabolic phenotype of this disease. And so since no data exists, we needed to make these measurements, and this is what we did. We made these measurements every other day in the ICU using ultrasound, using BIA, using metabolic cart, and then using echo. And we did these on the floor as well. And the first question is, are COVID-19 patients hypermetabolic in the acute phase? Well, there's some examples. This was a patient in the first week of ICU stay, mid-50s patient from a nursing home who weighed 60 kilos, who was not hypermetabolic. You can see they were 71% of predicted by Harris-Benedict. So in that first week, this patient was actually hypometabolic versus what the equations would predict. And so the equations here would have been very inaccurate and led to overfeeding of this patient. This is another patient. We'll see a number of readings from this patient. This was a mid-40s patient with COVID who also was very, very sick, prone and paralyzed, but only reading 78% of predicted. You can see So again, hypometabolic versus what the equations would predict, reading 78% are predicted. What about as the patient moves into the second and the third week of ICU stay in the chronic perhaps phase? Well, these patients actually become very hypermetabolic. This is that same patient, 49-year-old patient, was being fed 1440, now needs 35 kcals per kilo, 165% are predicted just a few days later from that first measurement. So this patient became dramatically hypermetabolic. And so we had to adjust the feeding for this patient. 165% are predicted by Harris-Benedict. So the equations are very inaccurate. Just 3 days later, they jumped to 200% are predicted. So again, patient needing 44 kcals per kilo, like a burn patient would need. So this was the COVID patient really showing us the severe hypermetabolism they can get. And then on day 18, you can see just 3 days later, they dropped to 1879. So they dropped dramatically in their needs. So again, you have to make regular measurements or you're going to be overfeeding and underfeeding your patients almost all the time. The equations are very inaccurate, as I'm going to show you. So again, in the day 23, the patient's needs went back up. We went back up to 2,300 calories. The RQ is showing a low RQ, so it's showing protein breakdown and underfeeding. And so again, this was a patient that we had really hard time feeding enterally, so we had to add parenteral nutrition as well. So this was the data from our initial critical care paper that showed that in non-obese patients, there was significant hypermetabolism after day 7. Before day 7, there was normal or hypometabolism, so there was a lot of variability in their needs versus Harris-Benedict. And this is Krista Haynes, who helped us. She's one of our trauma ICU physicians at Duke. She helped us graph this variability in 3-day epochs or windows. You can see the incredible variability. No equation could ever predict this. And again, prone positioning and paralysis didn't seem to have much effect on this. You can see a lot of these patients were prone and paralyzed throughout their stay in the ICU. And what we found was there was no differences in the effects on metabolic rate of proning or paralysis or SOFA score. So none of those affect the metabolism that we saw. So our initial data says that hypermetabolism had very minor very minorly affected by the severity of organ failure. And it was only had a minor relationship, if any, to paralysis and sedation. So don't change your feeds when you paralyze people. And this is not surprising. Arthur Van Zanten has shown that if you measure a metabolic cart before paralysis and after paralysis, there's only about a 6% change, which is trivial in actual caloric needs. So don't change your feedings when you paralyze. So how do these equations do in comparison to indirect calorimetry in COVID patients? So we took a larger set of data and we found out, of course, as you might guess, the equations perform very poorly and they really aren't accurate. So these are two of our research dietitians at Duke, Hillary and Laura. And now we're looking at 38 intubated COVID patients out to week 7 and comparing them to the equations that are commonly used in ICUs around the world. And this was just published in Clinical Nutrition FASPEN just a few months ago. And again, as you can see, the average age of our patients is mid-50s. They stay on the vent about 21 days. Their length of stay is about a month. And our mortality was about 30%. Now, this was pre-Delta. Our mortality has gone up since the Delta variant. And what we found was there was just consistent increase in all comers of caloric needs, even out to week 7. So this is not the typical Cuthbertson curves where they increase their needs and then they go back down after a week or two. These patients remain hypermetabolic out to week 7 when they remain intubated, like a burn patient would. They have severe prolonged hypermetabolism that we've never seen in any other critical care patient, short of perhaps burns. And you can see how the equations compare to, this is the measured indirect calorimetry data for the patients over the weeks. These are the FASPEN recommendations and the Penn State equation. You can see FASPEN nor Penn State is able to especially predict the hypermetabolism, and some of the equations overfeed early in stay and underfeed dramatically later in stay. And Harris-Benedict and MSJ equations were useless and not relevant to any of these patients compared to metabolic cart. So again, very poor performance by the equations. The interesting thing we also found was that non-obese patients seemed to have this hypermetabolic phenomenon, but obese patients didn't. At least through the first 3 weeks, our initial data showed there wasn't a change in the metabolic calorie needs of the obese patient. And so this is very interesting. We have not seen this before in any of our other critical care populations. And so we have a grant now from FASPEN, the US Nutrition Society, to explore specifically the effect of critical care in obese versus non-obese patients on caloric requirements. So you can see that the non-obese patients had increases in their hypermetabolism and their caloric need. The obese patients didn't seem to have that. So it's very interesting. This is just a summary showing that the equations perform very poorly across all weeks 1 through 7, pretty much across the board. This is more than 10% differences in orange. So again, we really need to have hospitals around the world begin to use metabolic carts to give the best feeding to our patients. So this study shows a unique and unreported hypermetabolic response to critical illness seen only in SARS-CoV-2 patients to this point, and perhaps in some severe burns. And it seems to be more significant in non-obese patients than obese patients. And again, indirect countmetry is essential for predicting targets in these patients. If you're going to pick an equation, it looks like the Penn State equation probably performs the best if you have to pick one, but it cannot predict the hypermetabolism that happens in weeks 3, 4, 5, 6, 7. So again, if we draw curves based on our actual data, this is what the curve of caloric need looks like, and perhaps less hypermetabolism in the obese patient. These are graphs we've drawn and I've published in a number of different places. I'm happy to email anyone these slides and these graphs if you want, that can help you think about how to use the metabolic cart and target the metabolic cart needs of your patients across time in these patients. Now, to close, just briefly, physical therapy also should be targeted. And so we have started a study at Duke that was funded by first FCCM, and then the NIH gave us $4 million to do a post-COVID rehabilitation study where we do cardiopulmonary exercise testing, CPET testing with a Bluetooth mask, a step test in the patient's room before they go home, and we target a high-intensity exercise interval training program to the patient that they go home with, and they 3 times a week do these HIIT training sessions with an iPhone and an iWatch that we give the patients, and a physical therapist interacts with them twice a week to coach them on their sessions. This is data we did in a bone marrow transplant population where we did targeted high-intensity training. You can see these are the heart rate intervals we get, and we coach the patients to get into their green zones. A lot of times they over-exercise, and they're not optimally exercising to their heart rates. We found these patients had 170% adherence. They exercised more than we asked them to, and they increased their VO2 peak by 25% in just 4 weeks. So we can dramatically improve physical function and exercise tolerance of these patients using this home-based high-intensity training personalized program. This is what the aims of our grant. We're going to have them go for 3 months with this training intervention, and then bring them back at 3 months and retest them. And then we're also going to bring them and check them at 6 months by phone for quality of life. So in summary, how to personalize the management of ICU and critically ill patients in nutrition and muscle mass and metabolism. I think the key message is here, this is our chance to really continue and improve our ability to create survivors of our patients and not victims. And we have a chance to do better, right? We have a chance to really know what our patients' caloric needs are and then ramp up our protein delivery as well. We really need to personalize how we target this. It's not just one feeding every day for every patient. It can't be that way anymore. And we must measure to be able to personalize our ICU nutrition and exercise strategies. And I think the presence of these new devices, the ultrasound, the BIA, the metabolic carts, that are now widely available and accurate and useful, are really hugely beneficial to objectively assess muscle, nutrition needs, and fitness in our ICU patients throughout and post their stay. So again, Lord Kelvin said it best, if we can't measure it, we can't improve it. And we have lots of opportunities to do this. We have ultrasound muscle mass and BIA and body composition to do perhaps before major surgeries. We have metabolic cart measures we can do while they're in the ICU. We can continue to get muscle and body composition data. And in fact, we can target exercise for our patients before they go home. And there's lots of other personalized treatments we can do that are summarized here. So again, I think in terms of feeding, you want to ramp your feeding up. You want to be measuring how much your patients need, and then that continues to ramp up and perhaps personalizing other treatments later in care. So again, I think if we can learn to do this, we can take patients with COVID and other diseases that look like this, have them exercising on their vents like this, and then ultimately leave the ICU like this, or at least like this. And with that, I thank you for your attention. I encourage all of you to follow me on social media. I try to post a lot of the nutrition and exercise data, the newest literature, to keep everyone informed. And there's great discussion that happens there. Twitter and Instagram are a great place to do that. And feel free to email me with any questions, or for these slides or any of the papers I mentioned, I'm happy to send them to you. And with that, thank you for your attention, and we look forward to discussing your questions.